Assalamu alaikum, everyone. I am very impressed that you all stayed here this late for the last talk. So I'm very impressed. I just want to thank the organizing committee and the entire Arab Thyroid Congress for having me today. Today I'm going to talk to you about management of low intermediate risk thyroid cancer. These are my relevant financial disclosures. So in 2024, you've seen lots of these numbers today. The incidence in the United States is 43,000. So the incidence had been increasing for many years. It's finally stabilizing out and now decreasing. Other cancers had stopped increasing a long time ago, but thyroid is finally catching up. Papillary is the most common thyroid cancer, as you heard earlier, with follicular thyroid cancer being the second most common. And together throughout the talk, we'll be talking about the low to intermediate risk of differentiated thyroid cancer. So we will not be discussing medullary or anaplastic thyroid cancer. So in terms of papillary thyroid cancer, you had a really nice talk by Professor Barletta on the WHO classification. Papillary thyroid cancer has specific nuclear features. Follicular thyroid cancer is defined by capsular or vascular invasion and has specific features. And then there's follicular variant of papillary thyroid cancer, which you heard about today, is now being reclassified into follicular thyroid cancer with the latest WHO. And there's many common subtypes, as she also went over. For today's purposes, for low to intermediate, there'll be the papillary, folliculars, and follicular variants of papillary. We will not discuss the oncocytic or insular, even though some oncocytic, which is the new name of Hürthle cell cancer, can be low risk. In general, the lower half of this slide is showing higher risk cancers. Non-invasive follicular thyroid neoplasm with papillary-like nuclear features is a lot of words, but basically this has been reclassified as non-cancer, so it's important pathology reads this out. And depending on your hospital how you follow this up, some are discharging them from clinic and some are following these up a little while longer. So the standard therapies of differentiated thyroid cancer is three-pronged, and this is how I explain it to patients. Surgery followed by radioactive iodine, and at recurrence, sometimes followed by more surgery and radioactive iodine, and then the third prong is TSH suppression, or giving the patient a little more thyroid hormone than their body needs. And so when we think about these three prongs, surgery again is the most important, but there's a lot of arguments in the societies as to how much surgery should be done. Do we do half a thyroid, a lobectomy, or a total thyroidectomy, and then do we do a lymph node dissection, and how far do we go? And when we think about radioactive iodine, we think about, are we ablating the remnant thyroid tissue after initial surgery, or are we trying to get rid of residual disease? And that changes how we think about radioactive iodine. And then thyroid hormone suppression. So I'll spend a little bit of time on surgery. It's the best chance at getting rid of the disease. It's the only time we dare to use the C word, cure. Otherwise, we don't typically use it in cancer in general. And the key is identifying a good surgeon. And many of you have great surgeons, which I think makes a very big difference, right, in terms of patients having residual disease and outcomes. Lobectomy is often used for small disease like a T1A, but depending on your institution and in the guidelines, you can use it for up to a 4-centimeter tumor, or what's considered T2 disease, in the absence of lymph node disease. And then, of course, if you have clinically apparent nodes in the central compartment or the lateral compartment, a total thyroidectomy is indicated with or without the lymph node dissection if it's clinically indicated. The guidelines for 2015, which are actually going to be updated hopefully this year, these are the latest American Thyroid Association guidelines, talk about a central neck dissection should be done if there's clinically apparent lymph nodes. The surgeon's eye is very important, as well as preoperative imaging, or if they have advanced disease like T3, T4. And lateral neck dissections should not be done prophylactically, but only in the clinically apparent disease. In general, molecular testing like BRAF was not recommended for decisions regarding the extent of surgery, even though you'll have several surgeons that use this. It wasn't recommended in the guidelines. Preoperative imaging was also emphasized. Before surgery, we should be doing proper neck imaging to help plan surgery. So even if that means that, for example, one doesn't have good ultrasound, or the surgeon wants a CT neck with contrast, it's okay, because good surgical planning is the best chance of getting these patients disease-free. So iodinated contrast will be, of course, delay the radioactive iodine, and I hear people worry about that all the time. We know from various studies that delaying radioactive iodine does not change outcomes, so let the surgeon get their CT with contrast, because that proper surgery is the most important thing. And then we need a good evaluation of the lateral nodes and central nodes. So a full neck ultrasound, not just a thyroid ultrasound, is important and was emphasized. And unfortunately, we get reports and it says thyroid ultrasound, and they're just doing this part here, and they're leaving lateral nodes because they're ignoring them. So this was for the surgical extent of disease to show you that the ATA guidelines does allow a lobectomy for up to 4 centimeters or a total thyroidectomy depending on your preference and what you see. And then if you do a lobectomy and you find that there's still disease later, a salvage completion is okay as well. But if you have greater than 4 centimeter tumor or gross invasion or with clinically apparent nodes, then a total thyroidectomy should be done as long as there's no contraindication. So when it comes to neck dissections, what was emphasized is that a prophylactic central neck dissection can be done in T3 or T4 disease, or anybody who has lateral disease, the central neck dissection should be done. And if you have lateral neck disease, you don't do a prophylactic neck dissection, you don't do prophylactic lateral neck dissection unless you have apparent disease there. So in terms of radioactive iodine, we all know that that's the original molecular targeted therapy, and it can be used in the adjuvant setting, meaning to prevent disease, which is mostly what people use it for, but you can also use it for treating disease, and most of our studies are retrospective in nature in terms of deciding the dose, except for the 2 randomized trials that we'll share with you. So there's not an ideal dose that is done, and that's why you hear all the arguments. But that the goals of radioactive iodine therapy is to decrease the recurrence rate and the risk of death, but most thyroid cancer patients, as you know, are at low risk for recurrence or death. Now, radioactive iodine makes our job easier for following them up because it makes the thyroglobulin go down, but the ability of a good neck ultrasound to pick up disease is underestimated. So we don't need to give iodine just so it makes our jobs easier. We need to do it if it's going to prevent disease. I show you this slide from a study over 23 years ago that does show that radioactive iodine, that disease-free survival improves with adjuvant radioactive iodine, meaning in the setting of not having cancer, giving radioactive iodine can lower the risk. But the question is, who actually needs that? So this is an old registry study that showed that patients who had stage 3 and 4 disease, okay, so higher risk disease, by definition, it was associated with improved overall survival, right? So giving radioactive iodine does matter in specific patients, but let's personalize the treatment and give it appropriately. And we have to remember that we're like, okay, even though radioactive iodine doesn't have many side effects, so let's just give it. No, that's not a reason to give it, because first, do no harm. Even if it's 1% of the time you get the side effect, if it happens in your patient, then that's 100% for that patient, right? They don't care that 99 people didn't get it. There's several studies and controversy about secondary malignancies from radioactive iodine, and if you look at all cancers, it was probably not increased, but if you specifically looked at hematologic malignancies and leukemia, that there may be an associated increased odds ratio in those cancers, and it may be connected with dose. The traditional approach to radioactive iodine was this simple: everybody should get radioactive iodine, and patients did great with minimal side effects. But there were several studies showing that a lot of patients with very small disease, so T1, which means less than 2 centimeters with no lymph nodes, and young patients under 45, over a third of them were getting radioactive iodine, and they didn't need to, right? So we've switched to selective use of radioactive iodine. So in general, don't give radioactive iodine unless the patient is high risk and that you know that it's going to lower their risk. So how do we know who is at risk for radioactive iodine? Well, we use the TNM classification, which is typically the size of the tumor, which is T status, whether they had central nodes N1A or lateral nodes N1B, and if they had distant metastases, yes, M1, no, M0. We use this TNM classification to then go into staging. Thyroid cancer is the only cancer that age comes into play with staging, because staging predicts death. The TNM status can be used for recurrence, but the actual staging predicts death, not recurrence. So for patients under the age 55, we only have stage 1 and stage 2. There is no 3 and 4 like other cancers. And it's no distant metastases, yes distant metastases, fairly simple, right? But if you have patients who are 55 years or older, you have the more traditional stage 1 through 4. Right? And so the higher the size of the tumor and the more the size of lymph nodes that are involved, whether it's on the side or in the center, the higher the risk of recurrence and death. So I tell all my trainees to print this page from the American Thyroid Association guidelines, because if you can look at patients and divide them into categories of low risk, intermediate risk, and high risk, on the left-hand side of this picture, then on the right-hand side, you can associate this with a % chance of recurrence of disease, right? So the patients on the bottom with the low risk have a 1 to 5% risk of recurrence. Radioactive iodine in the adjuvant setting, meaning after you've done surgery, cannot lower that risk. So those patients should not get iodine. Whereas those patients in the high-risk category that have anywhere in the order of 20 to 50% risk of recurrence, radioactive iodine, even if you don't see disease, can lower that risk, right? And so in general, low-risk patients, iodine is not routinely recommended. High risk, it is. The hardest job you all have is in the intermediate risk category, which is a large category. You have to have a discussion with the patient, do I or do not give you radioactive iodine? So let's look at an example. A patient with T1A, okay, which is less than a centimeter disease, no one would give iodine or shouldn't give iodine. But those patients who have T4, gross thyroidal extension, distant metastases, those are people you do give at least 1 dose of iodine to. And then everybody else is in the middle, right? Which makes it confusing for everyone, but at least it's better than giving everyone iodine, because we didn't think about the patient as an individual, personal, and personalized therapy. So I think everybody here knows that to prepare these patients with radioactive iodine, we need that TSH to be high to make the body hungry for the iodine, and you can do this under withdrawal conditions, taking them off their thyroid hormone, or under recombinant human TSH or Thyrogen. And so there was a long discussion for many years about how much iodine. There were observational studies that suggested that high dose is better, and there were prospective trials that said maybe not. And so the randomized trials that were published and done at the same time across the world, which was phenomenal that both of these came out at the same time, took patients with differentiated thyroid cancer after surgery and randomized them to withdrawal or recombinant human TSH and 30 versus 100 millicuries to help decide, do these patients do better, and does it matter if they get the lower or high dose? The two studies studied fairly similar patients. There was a little bit lower risk patients in estimable. They didn't have patients with T3 disease or T2 with N1. And their definition of a success was slightly different. In estimable, they needed to have an ultrasound and a whole body scan if their TG antibodies were positive. But in general, across the board, 30 versus 100 millicuries looked very similar, and the disease-free and recurrence rates were not determined. So what about TSH suppression? So nothing has changed much with the radioactive iodine, except we need to keep doing less, right? You saw some of the cases presented this morning, or this afternoon, actually, I'm sorry, and people are still blasting patients with radioactive iodine, right? We need to do better, and that's why this was emphasized more in the last guidelines. So keeping the TSH less than 0.5 is a form of cancer treatment, but we should personalize it to the stage, the presentation stage, and the cancer status at this time that the patient is in. So those who have stage 1 or low risk cancer, keep the TSH in the normal range, but in the what we call the upper normal range, which is the lower numbers, TSH 0.5 to 2, and the intermediate to high risk 0.1 to 0.5. But those patients with metastatic disease, less than 0.1 but not undetectable, right? And giving the patient that right amount and following them over time, it can make a difference even in the high-risk patients with metastatic disease and shrink tumor. I show this study from 1977, right, with the late Ernie Mazzaferri, where it was shown that thyroid hormone did reduce recurrence. But does it do that in everybody, and do we need to do that? So in the higher risk patients with stage 3-4 disease, similar to how we showed that radioactive iodine was associated with improved overall survival, TSH suppression is also associated with improved overall survival. So it does make a difference, and we do need to keep doing it. So how do we follow these patients up? So now they've had surgery with or without radioactive iodine. 85% of them will do well. 5 to 15% of them recur. We need to know if these patients are in that 5 to 15%. So a full ultrasound of the whole neck, not just the thyroid, should be done, and I can't emphasize that enough because we see patients over and over again who don't get a full neck ultrasound. Thyroglobulin should be checked in these patients, and thyroglobulin antibodies. So in the pandemic, we found out that a lot of outside labs, if you click the thyroglobulin, you don't get the antibodies, but 20 to 30% of thyroid cancer patients make antibodies, so both need to be ordered, doesn't matter where we are in the world. And to say the patient doesn't have any evidence of disease, both the thyroglobulin and the thyroglobulin antibodies should be negative, and the ultrasound of the neck should show no evidence of disease. What did change in the last guidelines is, okay, we know initially what the patient presented with high or low risk disease, but in follow-up we need to reassess. So we don't just say, oh, this patient had T1 disease, they're forever going to do well. You saw the cases today. That patient had, what, a T2 N0, and 15 years later recurred. So recurrence risk is dynamic. The risk of recurrence should always be reassessed every single time you see the patient. So there's 4 categories that were created so that we all use the same language across the world when we say this. Patients either have excellent response to therapy, biochemical incomplete response to therapy, structural incomplete, or indeterminate response. What do all these words mean, right? So if any of us say excellent response to therapy in our clinical notes, it means that there's no clinical or biochemical evidence of disease, right? So we did the imaging and the labs. And if they're biochemical incomplete, their thyroglobulin or thyroglobulin antibodies were abnormal, but the ultrasound didn't show any evidence of disease. Structural incomplete is those who still have disease that we know is disease in their neck or distantly. And then that indeterminate response is everybody else. Some nonspecific biochemical or nonspecific ultrasound findings that you're not sure what it means. The reason this is important is each of these categories, it responds to a different risk of recurrence. So if I walk into a patient, I tell them they have excellent response to therapy, I'm telling them that their risk of this cancer coming back is very, very, very low. Right? They still need follow-up for life. We don't stop thyroid cancer follow-up at 5 years. They get follow-up for life because we have delayed recurrences. But each of these categories, some of these patients with biochemical incomplete, those who had some thyroglobulin, it'll disappear on their own a third of the time. Right? So we don't want to blast these patients with more treatment. We want to follow them over time to figure out what's happening. The patients who are at highest risk of death are the structural incomplete response. Right? Those people who have known disease, either distant or local disease. And so again, this is a helpful chart that there's it's a modification of what's in the guidelines that helps us look at what are the expected outcomes for these patients in these 4 categories and what are the clinical implications. And it's very helpful to walk in to tell these patients. So we do have the first follow-up at 3 to 6 months post-surgery and or radioactive iodine with a serum thyroglobulin antibody with an associated TSH, right? Because as you saw in the clinical case today, the TSH and when we talk about doubling time of thyroglobulin, we need to look at it in the face, was it stimulated or suppressed? They should always be measured at the same time. An ultrasound of the neck should be done. CT neck is reserved for those who have high-risk disease to begin with, or in your area, ultrasound is not as good or they don't do the full neck ultrasound. What if patients have persistent thyroglobulin, right? Patients may still have that. Well, if the ultrasound of the neck is negative, we don't see recurrence of disease, and the thyroglobulin is low, most likely that's still coming from the neck, and it's okay to observe and continue TSH suppression. If the ultrasound does show disease, we biopsy it. Nobody goes to the operating room without a biopsy. You have to prove, even though you're excellent at ultrasound and you know it's disease, we all need to get a needle because we can be wrong. And multidisciplinary care, again, as you heard in the cases this morning, talking with the surgeon. What do we do if that thyroglobulin is elevated? Other than the neck ultrasound, because 8.5 times out of 10, that disease will be in the neck. That's where it loves to come back to. But the second most common place is the chest. So doing a CT scan of the chest to look for lung nodules or metastatic disease in the chest is important. The use of the radioactive iodine scan at least one time, whether you use treatment or diagnostic, you're allowed for an empiric dose of iodine or a diagnostic whole body scan. If you have positive thyroglobulin, negative whole body scan, we don't need to ever look again. It never changes back to iodine sensitivity unless you're redifferentiating them. Okay? So we call them radioactive iodine refractory thyroglobulin positive disease. The role of PET-CT is patients want to know at the beginning, why don't you just use a PET-CT and look at my whole body? Well, most thyroid cancers are well-behaving, do not take up FDG. So you can have an active thyroid cancer in your body and FDG be negative. So just because the PET is negative, it doesn't mean that the patient doesn't have thyroid cancer. So PET-CT is indicated, as you even heard earlier this morning with earlier this afternoon with the cases, is thyroglobulin greater than 10 or poorly differentiated histology. You can use it for prognostication as well. This is an older study that showed patients who had FDG positive disease had lower overall survival than those who had present thyroid cancer that was FDG negative. And the more lesions one had that was FDG positive, the lower the survival, right? So PET scan can be used for prognostic information, but in the right patient. With that, I just want to thank everybody that has worked with us over the years to treat thyroid cancer, and I want to welcome, I think we're open for questions, I'll find out from the chair, and feel free to email me and let me know if you need anything.
Thank you, Professor.